So today we'll talk, Assalamu alaikum. Today we'll talk about the adrenal gland disorders, especially we'll talk about the cortex, and I will skip today the adrenal medulla because I found it need really the whole lecture. So let's start talking today about the adrenal cortex. So I will walk you quickly through this slides. For anatomically, histologically, and also the layers. So as you know, we have two layers, for adrenal gland, two concepts. We have two outer cortex and adrenal medulla. So outer cortex has three layers: zona glomerulosa to secrete aldosterone, zona vasculata to secrete glucocorticoid, mainly cortisone, and reticularis to secrete androgen and sex hormones. Medulla will secrete catecholamines, mainly epinephrine. So the most important today is talk about how this. Sorry, I have some problem here. So the most important to know how these hormones, cortisol, aldosterone, act. If we have high cortisol or if we have low aldosterone, what will affect clinically our body. So at the beginning, we need to know aldosterone, cortisol, and sex hormones all have share the same precursor, which is cholesterol. Cholesterol usually is like starting point for all steroid hormone synthesis, but I don't need you to know all these details, just to know cortisol is the precursor of the aldosterone, cortisol, and sex hormones. We have two types of disease: hyperfunction, like Cushing syndrome. We'll talk about it now. This is one of the important, like, common diseases, and adrenal insufficiency. We'll talk about Addison disease and congenital adrenal hyperplasia. In adrenal medulla disease, the most important one and usually the famous one is pheochromocytoma. I'll skip it for another lecture today. So Cushing syndrome, to start, first of all, we need to know some important information as introductory information. So we have what we call it hypothalamic pituitary adrenal axis. So the hypothalamus, under any like stress mainly, or emotional stress, or any physical stress, will secrete corticotropin releasing hormone. We call it CRH, which stimulate the anterior pituitary gland to synthesize and release ACTH. That ACTH will be also act on the adrenal gland, especially on the zona vasculata to release cortisol. Now, this cortisol have also regulation. So by negative, when we have excess cortisol endogenously or either synthetic, we are taking like a steroid. We're taking steroids from outside, like IV, or taking pills or others like steroid tablet, and that will lead to a negative feedback on the pituitary and also on the hypothalamus. There is also another regulation like stress. Any major surgery, emotional stress also will increase the corticotropin releasing hormone, and also ACTH, and ultimately also will increase the cortisol. Also, ACTH and cortisol have, they are under what we call it diurnal rhythm or circadian rhythm. So morning will have high cortisol. So if we draw blood for the patient or any normal individual, not a patient, so we'll have it high at morning and less than 50% at afternoon. And this is usually because cortisol is important for energy and just like also the stress response, and that we keep it in balance between night and day and morning. And by the way, later on we will see with Cushing, cortisol will be, and ACTH, both of them, they will be high. And one of the important, guidance and investigation. So the morning and afternoon will be the same. So the patient will not have circadian rhythm, will lose circadian or diurnal rhythm. Cortisol, because it's hydrophobic, so it should be carried on albumin, or should be carried on any protein. So mainly will be carried 80 to 90% of the cortisol will be bound on what we call a CBG or transcortin or cortisol binding protein. while between 10 to 15 will be bound to albumin, and there is a free cortisol, which is usually biologically, this is the biologically active form, which is a free cortisol between 3 to 5. But what we measure in the lab, in the blood, we measure the binding globulin because this is the cortisol, which is usually circulate in our blood. So mainly when we measure glucose, cortisol in the lab for the patient, we are measuring CBG, which is CBG bound cortisol, which is cortisol binding globulin bind to cortisol. This is what we measure. So what we have in the blood circulation, this is, I need you to know it, we measure the CBG here. While the biologically active one is the free one, which is between 3 to 5. So as I mentioned before, so we have circadian rhythm here. So that's why when we collect the cortisol and the plasma, we take it as we want to investigate about Cushing or other diseases. So especially for Cushing, we have to measure it morning and between 8 to 9, and also afternoon between 10 to 12. Usually we have temporary spike for the hormones and maybe observed as a response to emotional stress. And that's why if the patient has, like the phlebotomist in the lab or nurses as well in the ward, if they found the patient has in their the orders cortisol, they ask the patient, advise them or advise her to stay to wait in the waiting area for 10 to 15 minutes, because this is important, because with the patient they are panic or they are like exhausted, walking a lot. So we don't want to have that spike, temporary spike of increase of cortisol. That's why we keep them to calm down. And then after that, we will extract blood or to draw blood for the patient. So here, so when we want to investigate about Cushing, so we take blood for the patient morning and afternoon. And also we have another also source, which is urinary cortisol. Cortisol usually will be inactivated and conjugated in the liver to be excreted through kidney in the urine. While there is small fraction of cortisol will be excreted unchanged in the urine, we call it UFC, which is urinary free cortisol. This is all important because it's part of investigation of Cushing and Addison as well. I don't want you to memorize any numbers at all, but just to know, urinary free cortisol is less than 20 to 150 nanomole per day. That's mean normal, but usually most of the patients, they don't have that compliance to collect 24 hours. So we do something else, which is random, with early morning specimen of urine, and we put that the ratio between cortisol and creatinine. So if it is diluted, the creatinine will be low, so it will be like adjusted, or vice versa. If it's concentrated, the urine is concentrated, also the creatinine will be high, and that will give me like estimation about the correct measurement of cortisol. And usually should be less than 25 micromole cortisol per 1 mole of creatinine. I don't want you to know numbers, because when I will, in the exam, I will give you the reference range, and I will tell you if this is high or low. And just you need to know the diagnosis here, interpretation of the result. No need to memorize numbers. So when we can find cortisol, if we draw blood from the patient or individual, any person, and so we have to, and we found the cortisol is high. So we are here, we have two scenarios. One, real high cortisol, so our body produce more cortisol here, like Cushing syndrome, exercise, stress and anxiety, obesity, alcohol, chronic renal disease, renal failure. So all of these, usually when we want to investigate about Cushing syndrome, so we need to rule out all of these: exercise, stress, obesity, alcohol, and others. And we call it pseudo Cushing syndrome. While when it's like confirmed, so we rule out all of this, and still after the investigation, we'll talk about after screening and confirmation, still we have cortisol high. So we call it a true Cushing syndrome. Here, if we have really high cortisol production from our body, So even the pseudo we have in exercise needs to have high cortisol, stress and anxiety and depression needs to have high cortisol, but it's all also obesity have high cortisol like metabolic syndrome and alcohol as well. But also this is all we have high endogenous cortisol from our body. But there is also something else, which is it's not because our cortisol is high in our body, but because we have more, as I mentioned before, or our cortisol in our body carried by CBG, by cortisol binding globulin. So if we have, if the liver synthesizes more CBG under stimulation of estrogen, either due to pregnancy, due to any congenital diseases, or if the patient on estrogen therapy or oral contraceptives, all of these things leads to have high CBG, and they have to have more binding cortisol, and that will give me like that false explanation that we have a high cortisol. That's why when we have unexplainable high cortisol, we have to go to see if the patient taking estrogen therapy, or if she's pregnant, or oral contraceptive. So what the effect of cortisol? So I think you study it, but I will summarize it very quickly. So cortisol always is like an insulin antagonist, likes to keep glucose high. So usually it's important, and this is usually for stress, as a stress hormone. So in the liver, for example, if we have we need cortisol to keep the glucose high by gluconeogenesis, to also have increase the amino acid uptake and degradation, all just to increase the fuel, increase the energy here, increase the ketogenesis, all these things in the liver. In adipose tissue will increase the lipolysis, all of these things for the glucose just to increase the energy. In the muscle also increase the proteolysis. This is good, and this is very effective. It is for temporary, as respond to stress, as respond to any other important thing. But if it's a chronic increase of cortisol, it will lead to a disease like Cushing syndrome, and we will have fat redistribution, we have muscle weakness, we will have diabetes. So it's usually this is cortisol have important uh, uh, action on our body and enhance metabolism of different um, products in our body, but at the same time, if we have it high, increase the chronic glucose. Somebody talking. If we have it in this way, so that leads to, as I mentioned, uh, diabetes, um, muscle wasting, fat redistribution in a different way. And the usually clinical criteria of Cushing syndrome: weight gain, central obesity, as I told you now, fat redistribution, buffalo hump, moon face, excessive sweating, atrophy of the skin, hirsutism, and others. Loss of signs, loss of the urinary rhythm for cortisol and ACTH, as you can see here. So in Cushing, it will be all stand or like in the same level. Hypertension due to aldosterone. So because cortisol has also aldosterone-like effect, so we'll have hypertension, hyperglycemia or diabetes due to insulin resistance, hypokalemic alkalosis, hypokalemia because we will study now addition. So usually aldosterone usually increase the absorption of sodium and water and increase the excretion of potassium and hydrogen. Excretion of potassium that leads to hypokalemia. Excretion of hydrogen leads to alkalosis. That's why patients with Cushing will have also hypokalemia and alkalosis, increase the protein metabolism and impaired immunity as well. So how we can investigate a patient with Cushing syndrome? At the beginning, this patient will come through clinic, not through emergency. So you will see the patient for Addison will come through emergency department, while this patient will come through mainly through either um, mainly it's endocrine or diabetic clinic or endocrine clinic. So we have two steps. First of all, screening and confirmatory, and then we will need to have further investigation of already confirmed Cushing disease to know the pathological lesion. Like we need to know the source. Is adrenal cortex, the pituitary, is ectopic, like it is from with lung cancer with neoplasm in the cancer, or nature of pathological lesion. Is adenoma, is a carcinoma, is benign, is not benign. So all of these things we need to study. As screening, so patient will come to the clinic. So like, for example, she is obese, has hirsutism, depressed. So the endocrinologist need to rule out or the confirmed diagnosis of Cushing disease. So will give the patient dexamethasone, which is synthetic cortisol, and advise the patient to take it at night and come morning to draw blood. The patient will come and the lab will take blood for this patient. So if the cortisol is suppressed less than 15 nanomole per liter, which is self-suppressed, so if we measure the glucose and we found it's less than 15 nanomole per liter, that's mean the cortisol suppressed, as I mentioned before. So when we take cortisol, either the body produce more cortisol or we take cortisol from outside, it would lead to negative feedback on the pituitary and also on the hypothalamus. So, and that's it to decrease secretion of CRH and ACTH, and that will lead to decrease also the production of cortisol or secretion of cortisol from the adrenal. And that's what we call it suppression. So when we take cortisol from outside, that will give me the negative feedback. So the day after, when I will draw blood and measure the cortisol, should be normally for a normal person, should be less than 50 nanomole per liter. And I need you to know that when I will say suppressions, you need to understand what the meaning. Here, I don't want you also to do numbers, because in the exam, if I bring you cases, I will say suppression or not suppression. This is, you will understand what I'm talking about. So if it is less than 50, so that will exclude a Cushing, exclude high cortisol or hypercholesterolemia. Here I put some, like it's something important. Clinically, you will notice it. So if the patient have epilepsy and it's and she or he under phenytoin or phenobarbital, so what you have to increase the dose. If the doctor cannot stop the medication, increase the cortisol dose, because we give like 1 milligram of dexamethasone. Here maybe the treating physician or the endocrinologist will give 2 milligram, because they found this phenytoin and these drugs will increase the metabolism of the cortisol, and maybe we'll have false diagnosis of Cushing, because the suppression will not be, the cortisol will not be less than 15 nanomole per liter, and we will find out maybe there is no suppression and cortisol is still high, and we will diagnose the patient as a Cushing disease patient or Cushing syndrome patient, I mean. So also another type of screening to measure 24-hour urine cortisol. And so before I mentioned that, so if it's less than 250, we can say also exclude Cushing. So, but disadvantage, so sometimes the patient cannot complete the collection of urine. Also, we have another, this is new things like the in textbook to add midnight salivary cortisol. Also, of cortisol in the saliva less than 100 nanogram per deciliter, also we exclude Cushing. So how we can confirm it? We need, now we talk about the three. We talk about low dose dexamethasone. We give the patient at night. Dexamethasone, measure it at morning from the blood. Also, we measure in the urine and we measure in the saliva. To confirm it, we need 2 out of 3. Like if we have blood and urine or blood and saliva, it's enough to confirm it. So how to investigate about the causes now? I need to know, we have 3 possibilities: adrenal, pituitary, or hypothalamus, or maybe something we talk about it now, it's ectopic. So some cancer can secrete ACTH and act on the adrenal. It's not it's pituitary, it's something else, not located in pituitary. This is a tumor, it's in the lung, and can secrete ACTH and stimulate the adrenal to secrete more cortisol. So how to investigate? Now we need to know, first of all, we need to know ACTH dependent and ACTH independent. What the meaning here of ACTH dependent, ACTH dependent, I need to go with you to this one. So we have two types of hyperfunction or Cushing syndrome. Either pituitary, which is, let's talk about it with the high percentage. So usually when we want to discuss Cushing syndrome, first of all, we think about pituitary hyperplasia or pituitary adenoma, because mainly the 90% of Cushing syndrome is Cushing disease. So we have two terminology. Cushing disease, which is like one of, like under the umbrella of Cushing syndrome, but usually this is the most common. Second one is ectopic, as I mentioned, it's like usually from cancer, mainly it's lung cancer, which is less than 10%. And this is all secreting ACTH, that's why we call it ACTH dependent. Another type, which is ACTH independent, so not due to, so we have high cortisol, but not due to ACTH stimulation. Is it already in the adrenal? We have 20%, 10% for adenoma and 10% for carcinoma. So we have a tumor in the adrenal gland, or sometimes it's due to glucocorticoid therapy. But mainly here, if we are not talking about something from outside, so the most probably it's pituitary adenoma, which is 90%. Then we have adrenal tumor, either adenoma or carcinoma, which is 20%, or ectopic due to lung cancer, which is 10%. Why we call it ACTH dependent? Because here the cortisol will be high due to a stimulation from ACTH. Why we call it ACTH independent? Because here due to adrenal itself secrete a lot of cortisol, or we are taking cortisol from outside without any influence from or by ACTH. Let's continue here. So we talk about this one, and also we need to distinguish between ACTH dependent, like now we'll talk about how we can distinguish between pituitary and lung, and also we'll talk about radiological investigation, and also we'll talk about IBSSS. So at the beginning, we understand what the meaning of ACTH dependent and ACTH dependent. As I mentioned before, disease is a part, Cushing disease, which is the most common, which is pituitary. It's part which is under umbrella of Cushing syndrome. So Cushing disease is a specific subtype of Cushing syndrome caused by pituitary tumor. If we measure ACTH here in the blood, morning and afternoon, if it's undetectable, like it's mainly we cannot, like it's very, very low concentration in the blood. So here we have to think about adrenal tumor, and we can confirm it by CT scan. By why it's due to adrenal? Because when we have adrenal tumor, so we have high cortisol, and we will have negative feedback on the pituitary. So pituitary will not secrete ACTH. That's why we cannot. It will have low amount of or low concentration of ACTH in the blood. While if ACTH moderately increased, and we have to think here about pituitary disease or Cushing disease, I mean, or pituitary dependent. So we have pituitary hyperplasia or adenoma or carcinoma, and it's all due to, this is what we call Cushing disease, and that would lead to increase the ACTH moderately. If ACTH is very high, and here we have to think about ectopic with something like lung cancer, it's and why you have to ask me question. So if it is like both of them, which you told us about ACTH dependent, and why it in pituitary or in Cushing disease and pituitary dependent ACTH is moderately increased, why it's very high in case of ectopic? Because even if it is pituitary and we have like hyperplasia or tumor in the pituitary, but it's still regulated by hypothalamus pituitary adrenal axis, and still there is some influence of the cortisol negative feedback. While here, in the ectopic because it not belong to this axis, hypothalamic pituitary adrenal axis. So, and this is outside of this axis. That's why it usually ACTH will be very high. So second uh, steps to differentiate between pituitary and ectopic here. So what we do, we give the patient now not just one overnight, one small dose of dexamethasone, we'll give high dose of dexamethasone. I want you also to know something. When we have hyperfunction, we give suppression. Well, we'll talk about Addison because it's hyperfunction. You will find we will give stimulation test. So always we need to know that things. When we have in the exam when we talk about hyperfunction Cushing, you have to think about dexamethasone suppression as a low dose and high dose. When later on we talk about Addison, you will find we're talking about stimulation test. We will give ACTH because we need just to stimulate the adrenal to secrete some cortisol. Let's continue here. So we will give 2 milligram for every 6 hours. I don't need you at all to memorize 6 hours for 48. Just to know, we call it high dose dexamethasone suppression test. And I don't want you to memorize numbers at all. So, but just I put it just to understand. So it will be like more, let's say, you can understand it better as a clinician here. So they will give the patient, but first of all, usually it will be, this patient will be admitted in the hospital. The low dose, we give the patient at home, take it at home because it's just one tablet and go. Here we need the patient to be admitted because we will keep giving we have to measure the baseline and we need to measure every 6 hours this the cortisol and ACTH. So as I mentioned before, we have to all of us agree that suppression is defined as a full of less than 50% of basal value. This is like usually when we say suppression, this is the meaning of suppression. They found if the patient has Cushing, this is like due to pituitary adenoma, so 90% of the patient will respond of the high dose of dexamethasone, while for ectopic just 10%. So usually we neglected this person at this 10%, and usually we say so the patient will respond, and there is a suppression with the high dose of dexamethasone for the patient of Cushing disease, and no suppression with the high dose of dexamethasone for patient with ectopic ACTH production. Understood? واضحة? I don't know, but let me continue. So high dose for 2 days to suppress the pituitary or to suppress secretion of ACTH. If starting to respond, that means it's pituitary. If no response, that means it's ectopic. So what other laboratory findings we can find in high blood WBC, and we can find high blood glucose, hypokalemia, metabolic alkalosis, and sure we have ACTH with adrenal, and ACTH is pituitary. So another radiological investigation, this is maybe radiology department will talk about it better, but we need to confirm if it is due to Cushing disease. We can do MRI for the patient, and we can find pituitary microadenoma as well, like this picture. And also there is another also way when we call it inferior petrosal sinus sampling, IPSS. This is how they do it, just to confirm, just to know, make sure it is ectopic or it's pituitary. Usually, normally, they take the sample from the drainage directly to the pituitary sinus. It has like a way, surgical way, and also measure it in the peripherally, like extraction of the blood, normal extraction. Usually should be, if it is pituitary source, so usually the central, the ratio between the central and peripheral should be more than 2 And if we give the patient also CRH stimulation test, it should be more than 3. If it's ectopic, should be all the ratio between the central and peripheral should be normal, should be 1, less than 2. And this is important for them. Then sometimes they done it, sometimes they just make sure if MRI already positive here, they don't need to do that. If they didn't find any, like by MRI, any, because sometimes it's very small, it will not be macro, it will be very micro, and they cannot detect it, and they cannot detect anything in the lung, so they will go with, this is the last, like we call it the last way or to find the solution here, if it is pituitary or neoplasm from the lung. So they do their things. So they go to study it is central or peripheral ACTH. So as I mentioned, if the ratio more than 2, this is pituitary. If it is no less than 2 or 1, it's mainly ectopic. So this is like the cascade, what we study. So at the beginning screening, we use low-dose dexamethasone, urinary free cortisol, UFC, midnight delivery. We need 2 out of 3. If it is positive, so we have to proceed to study more Cushing syndrome. And as we know, we have ACTH dependent and ACTH dependent, so we need to measure ACTH. If it's very low, that means it's adrenal, and it is high. So here we need to differentiate it's ectopic or pituitary. So we do a pituitary MRI here. If we found it, if we can find something here, so it is confirm the Cushing, and also we need also to do high dose dexamethasone. If it is within, that's a confirmed Cushing disease. If it's not, if negative, we need to go for something else like IBSS. And after that, we can go for chest X-ray and others. So just to investigate more about lung cancer. Let's share with you this case. 58 years old man admitted with weight loss, respiratory distress. I would like underline just under the important like words: respiratory distress, weight loss, pigmentation, blood pressure is 140 over 80 is high, a little bit high blood pressure. Here we have hypokalemia, cortisol very high, with the low dose post overnight still high, no suppression. Further investigation also we done for this patient, not just post overnight or low dose. We make also the high dose dexamethasone suppression test, also no suppression. We measure the ACTH and we measure the cortisol all the time. They're still high, and also no diurnal rhythm, no circadian rhythm. So with all this clinical investigation, with also the weight loss and the respiratory, we found that patient has Cushing syndrome due to ectopic ACTH production. Let's know any question for Cushing. We are doing well? Because Anna, I don't see anything. I close everything just to give my lecture. If you have any question, please, you can tell me. I cannot read the chat. And then now, good, fine. Can you hear me?
Yes, doctor, everything is okay.
Good, good. I need just at least one answer just to understand, to make sure you are with me. So let's start with addition. So at the beginning, so when we talk about Cushing, we study the cortisol and we talk about hyperfunction and all the investigation for suppression. When we talk about addition, we'll talk about aldosterone mainly, and we will talk about how we can investigate by having more stimulation of the adrenal gland. At the beginning, aldosterone is important here. Cortisol, we talk about its insulin antagonist, its catabolic hormones, have like it needs lipolysis, lipolysis, ketogenesis, glucose. So this is talking about cortisol. Aldosterone is a different story. Aldosterone, like always, is like the mainly work for water electrolytes and blood pressure. Always the thermometer of aldosterone is blood pressure and sodium and water. And this is like all, this is the area of aldosterone. So aldosterone acts on the digital computer tubule to increase excretion of potassium and increase absorption of sodium and water. There we talk about what we call it hypothalamus pituitary adrenal axis. Here we talk about renin angiotensin system. This is like the axis of the aldosterone. So renin uh, usually it's a proteolytic. What the meaning of proteolytic enzyme? That means the proteolytic, like you know the amino acids. No, I mean the protein consists of polypeptides, and if it is more than 12, it's polypeptide, and this one it's all amino acids here. So some of a product it can have proteolytic. This enzyme have, or some protein has proteolytic activity. That's why we call it because can cut this polypeptide chain to give me a smaller one. So renin produced by juxtagranular cells of the afferent renal arterioles. So it is this cells located in the afferent renal arterioles. But this renin always found there, but how we stimulate these cells from afferent renal arterioles to be secreted while we need now renin when we have, because they have baroreceptors, have very sensitive blood pressure changes, like have baroreceptors very sensitive to any blood pressure changes. So let me explain it again just to not make you confused. So aldosterone here, we will see now aldosterone regulated by renin-angiotensin system. What is this renin-angiotensin system? Let's just talk about this story from the beginning. Renin secreted from or by juxtagranular cells. And these juxtagranular cells located in the afferent renal arterioles. So how these cells, this cells has baroreceptors or has a receptor. These receptors sensitive for three things. If there is any change in blood pressure, if there is low volume of blood, also there's a less of renal perfusion or less sodium. So for anything of like this, like less sodium, less blood pressure, less volume, blood volume, that renin will be stimulated, juxtagranular cells will be stimulated to secrete renin. This renin has proteolytic activity, so it can cut the polypeptides. Angiotensin, this is a protein made in the liver and after that released in the circulation, but it's in active form because it's big, bulky protein found in the blood circulation. When we have excess, what we usually found in our blood circulation, when we have low blood pressure, the afferent renal arteriole with the juxtagranular cells secrete more renin, and that renin in the circulation will find the angiotensinogen, and that renin will cut this angiotensinogen to form active form, which is called angiotensin 1. Angiotensin 1 now in the circulation also will meet another product, we call it angiotensin converting enzyme, to convert angiotensin 1 to angiotensin 2. The most important, the star here in this mechanism, angiotensin 2, because it has two roles here. First of all, vasoconstriction, to keep the blood, so to increase blood pressure, and also to stimulate the adrenal gland to release, to secrete aldosterone. So when we have aldosterone here, the kidney will increase the absorption of sodium and water, and it's increase the excretion of potassium. Now, I'm not talking about potassium, let's talk about sodium. Usually when we increase the absorption of sodium, that means sodium always pulling the water with the sodium. Here I increase the volume of the blood and also with the vasoconstriction. So increase the volume of the blood by having sodium and water more, and also the vasoconstriction. By these two ways, I increase the blood pressure. I put back the blood pressure to the normal normal situation. But I don't want blood pressure to increase all the time. So angiotensin 2 also has feedback activity, negative feedback, so will increase or inhibit renin release. And also angiotensin 2 will be degraded to inactive form, which we call angiotensin 3. This is how we can maintain our blood pressure so if the patient come, for example, to the emergency with a trauma, has a low blood volume, has bleeding, so here you will find our juxtagranular cells will have an afferent reactor will be to stimulate the renin, and that renin will go to cut that angiotensin gene to angiotensin 1, and in the blood circulation, then will be converted to angiotensin 2 will go to do vasoconstriction, ask adrenal to secrete aldosterone. Aldosterone will increase the absorption of sodium, and sodium will pull with it the water, and here will increase the volume, and the blood pressure will go stabilized again to the normal reading. So what is the causes of adrenocortical hypofunction? We have two causes, either primary or secondary. When we talk about Cushing disease, we talk about pituitary. When we talk about Addison, we talk about adrenal. So there, the most common one is pituitary adenoma. There in Cushing disease, here Addison mainly from adrenal, either due to autoimmune disease, infection, or tuberculosis, infiltrative lesion like amyloidosis. This is all due to primary adrenocortical hypofunction. Or secondary, not due to adrenal, like pituitary tumors, vascular head trauma, hypothalamic, and iatrogenic taken from outside. I need you here to remember something because later on we will use it in the investigation. When we talk about a primary adrenocortical hypofunction and destruction, so here the adrenal is already destructed, or adrenal glands, or adrenal cells. So even if we give ACTH for this to the adrenal from outside, it still will not work. While in secondary, the adrenal is still intact, but there is no stimulation for it. There is no ACTH. There is so the adrenal gland, the gland is asleep, so but still intact. I need you just to keep this information for you because we will utilize it later on. In conclusion, we have two types: primary, which is Addison disease, or secondary due to Addison disease due to adrenal itself, adrenal gland itself, autoimmune or infection or others. Secondary adrenal is intact, but something else happened above the adrenal. I mentioned before, in Cushing, the patient will come maybe depressed, obese, if she is girl, infertile, has the hirsutism, others, but come through clinic. This patient will come through emergency because the patient will have lethargy, weakness, nausea, weight loss, hypotension, we'll talk about hyperpigmentation now, deficiency of both glucocorticoid and mineralocorticoid, has low sodium, hypoglycemic, high potassium, and raised urea. Why the patient has high urea? Any clue? I've been in the exam. Any clue? Why has urea?
Maybe because there will be acidosis, so the body will try to compensate.
Let's maybe, but let me tell you something. So when we have, I mentioned before, like when we have sodium, when we have aldosterone high or aldosterone normal, aldosterone what will do? The aldosterone will increase the absorption of sodium, and sodium will pull with it what? The water, right? So we will have enough amount of sodium and water, right? So now we have low sodium. Check there here, it's with the arrow. Now we have no sodium. So you expect the water will be high or less in our blood circulation? Water will be less or more? Because when we have high sodium, we will have more water, right? So when we have less sodium, we will have less water. And usually when you have low concentration of, when you have less water, the concentration of any product, even if it's normal, will be high. And so like if we have like 1 glass of water and you put less water and the same amount of salt, here we'll find like this glass is salty and the other, even it's 1 spoon, you will find it normal. So because here loss of water, less hypovolemia this patient has and less water and hypotension, and the patient cannot even standing because of the hypotension, weight loss, nausea, cannot eat, weakness. So will the concentration, even if usually urea when somebody eat, but he cannot eat, he has weight loss. It's not because like yesterday eat a lot of, for example, usually urea comes from when we eat a protein the night before, and after that we can find high creatinine and urea, especially urea. But here the patient cannot eat, weak, lethargy, have lethargy. So it's due to hypovolemia. And this case is usually is life-threatening and need. So here in this one, we will not, first of all, we have to stabilize the patient. We give the patient dextrine, give the patient saline with glucose and salt and others, and stabilize the patient. After that, we will start to investigate about it is addition or non-addition, is primary or secondary. So first of all, we have to treat the patient. And that's why I was saying this patient will come through emergency, not through a clinic. So let's study the hyperpigmentation. And also in the case there, in our case for Cushing, when we talk about there is ACTH, high ACTH, and due to ectopic, what we call it, cancer. Also, we talk about hyperpigmentation. Anything, when I say hyperpigmentation, in any case, you have to know ACTH is high. This is like, you have to know. So it was found when we have ACTH high, always we have hyperpigmentation. Why? Because they have the same, they share same precursor, which that precursor is called POMC or pro-opiomelanocortin. Because this pro-opiomelanocortin, when have part of it ACTH and the other MSH. What is that MSH? Melanocyte stimulating hormone. And also ACTH, anti-pituitary POMC also cleaved into ACTH and gamma MSH and beta lipoprotein. And furtherly, ACTH also can be cleaved to alpha MSH, where they found alpha MSH the most important one for melanocyte stimulation, to have pigment or melanocyte producing and the skin pigmentation. That's why when we have ACTH high, so here we have two types of, like two sources of melanin or melanocyte, what we call stimulating hormone. One, it is gamma MSH and the other alpha MSH. One from POMC and the other from ACTH itself. And the most potent one for skin pigmentation is alpha MSH. MSH هي abbreviation of اختصار of melanocyte stimulation hormone. So any case we find, so it can be found in ACTH dependent hyperfunction of like Cushing syndrome or in addition, but it will not be found in secondary adrenal cortical insufficiency, because in secondary we have a low ACTH. So the investigation will be, the patient will be hospitalized, serum, because I have to make sure, I have to run here. That's why I deleted and removed pheochromocytoma, because no time to cover it all in 1 hour. So we need to study the first of all, patient should be hospitalized, then we have to measure all what we talk about it. And then after that, we need to, in addition, the low serum cortisol and ACTH will be high. So in addition, we'll have low serum cortisol and ACTH will be high. So how we confirm it? We do what we call it short synectin test, or we give the patient ACTH. But the meaning of this, I don't want you to know what that tetracozactin, don't memorize it, but this is Latino language. Tetra, that means 4. Cozactin is 24, that means 24. 20. Cozactin, this is 20. So tetracozactin, it is about like 24 amino acid, which is active amino acid, is active peptide in the ACTH. That's why they call it a short ACTH stimulation test. Now, this is like the active form of ACTH. Synthetic ACTH is the 24 amino acid, the active one. So at the beginning, we measure the basal, and then we give the patient ACTH stimulation test. Normally, it should be the cortisol will increase. Failure to respond, that means confirm additional disease. Why it will not increase? Because already the cells of the adrenal, due to infection, due to anything, it will be, sorry, it will be not working. So also, if there is any autoimmune disease, we have to measure adrenal antibodies, and also we'll have to support it also with radiological investigation, ultrasound or CT scan. Investigation of the secondary, if we both of them low, you put secondary. If one low, one high, put primary. This is, you have to remember it. So what we do for secondary, we call it depot. Depot, like prolonged synectin test. So we don't give it one shot, we give it for 3 days, and we measure the cortisol. They found that patient with Addison, no rise in cortisol, even if we give prolonged ACTH. But for secondary, when the reason is due to pituitary problem or whatever, but the adrenal is intact, they found there is a stepwise, like gradually increase of serum cortisol after successful injection. Who will explain to me this one? Why Addison didn't have any increase in cortisol, while in secondary there's an increase, although at the beginning we don't have at all cortisol, both of them. We have hypofunction. Although that in secondary they didn't respond to the short ACTH for the first dose, like 1 dose. Like when we give here short synectin test or short ACTH, both of them didn't respond, secondary or primary. The answer here, because in secondary, the adrenal gland is intact, but asleep, like lazy, because no stimulation long time by ACTH. But now, by repetitive ACTH stimulation, started to be awake and started to secrete some of cortisol, and that's why we call it a stepwise increase, like gradual increase of serum cortisol. In summary, we have this. I need you just to know these two table, Hadi, this one and that one. Here, for screening for Addison, you have high ACTH and low cortisol. This is the most important. These 2 slides, the most important thing we talk about it. And hyperpigmentation is important. There's 3 slides, hyperpigmentation and these 2 investigation in conclusion. High ACTH and low cortisol. In screening, confirmatory, short ACTH, no response, and we can do adrenal autoantibodies. In secondary, in screening, both of them low. For confirmation, low, long ACTH or depot synectin test, and we have stepwise increase of serum cortisol. I don't want you to know this others insulin-induced. This is not now talking about it. So I need you to know these 2 slides. Screening for Addison, Addison screening, both of them low. Confirmation short ACTH stimulation test, no response. Second one, and secondary, both of them low. Confirmation by long ACTH stepwise increase, and the other one don't study it. And let's conclude with this case study. So this patient came to the GB to have tiredness, loss of appetite, weight loss, dizzy, and also had low blood pressure, hyponatremia. Here we can see in the red cortisol after 30 minutes of post-synectine after they give him ACTH, 190, so it didn't increase. There is also anti-adrenal antibodies, strong. So most likely this patient has Addison due to autoimmune primary adrenal failure. Due to this, some Addison, the autoimmune disease. Those patients usually given a glucocorticoid, mineralocorticoid, and replacement. So I will take from you, just allow me to take 5 minutes quickly. I will not explain all of this one. I don't want you to memorize this, just I will give you one of the examples of congenital adrenal hyperplasia. Congenital hyperplasia is one of the groups in inherited disorders caused by enzyme defect of steroid biosynthesis in adrenal gland. So let's go to this one. I don't want you to memorize anything of that. Just I want to explain to you one thing. So we agreed at the beginning of our lecture today, cholesterol is a precursor of aldosterone, cortisol, and estradiol. Now here. So and we have like pathways. All each reaction we have like precursor, enzyme, and after that the product, end product. So end product now will be precursor, and we have another end product, and this. They found sometimes there is a gene, a mutation of one of these enzymes, and that mutation leads to deficiency partial or complete deficiency of one of these enzymes. So usually when we have deficiency, so what will happen? The end product will be less, and the precursor will be high. And by this pathways, you will find always cortisol, aldosterone will be low, cortisol will be low, and usually what's open here, we will find the pathway of the sex hormones. One of them we will study, which is the most common one, but I don't want you to study all of this. So here, when we have some of enzyme defect in steroid biosynthesis, so that leads to cortisol production will be low, no negative feedback, so ACTH will still high. That's why we call it adrenal hyperplasia, because stimulate the adrenal, and the adrenal will be big. That's why we call it adrenal hyperplasia. Accumulation of steroid precursors, as I mentioned, according to the pathways. We don't know which one, but we can go one by one. This is what we studied postgraduate. This is in the pathology we studied. Aldosterone production decrease and leads to electrolyte imbalance as well. And so we'll have hyponatremia and hyperkalemia, and clinical significant life-threatening if not diagnosed early, requires prompt recognition and management. So we have the most important is types, 21 hydroxylase deficiency. This is the most common. I don't want you to know the others, but I will explain quickly this one. So here you can find when we don't have 21, we have a mutation in the gene of this enzyme 21 alpha hydroxylase. So we cannot convert this progesterone to deoxycortisol or the other pathways. So what will happen here? So we will have or 17-hydroxyprogesterone deoxycortisone. At the beginning here, if you go with me here, when we don't have 21 hydroxylase deficiency, so first of all, I will not have aldosterone, and also I will not have cortisol. What I will have 17-hydroxyprogesterone high. So usually this is what we measure this is part of newborn screening program for the babies. You know, there is 18 disease we have to screen every baby. That is policy, national policy. No any birth date any birth happen in the hospital will go unless we do for the patient newborn screening testing, which is usually take it from the heel of the baby. We call it heel prick, put it on filter paper, and we do 18. We have it here in our hospital. This is called newborn screening program, which is national program. Part of it is congenital adrenal hyperplasia. So what we measure for this baby, we measure 17-hydroxyprogesterone. If it is high, usually we wait for 48 hours. So we keep the lady, the mom, with the baby 24, because usually we don't want to measure it quickly for the baby, because sometimes we are measuring the blood of the mother. So we will have to wait for 48 hours. After that, we will measure it. We will not allow to the mother and baby to be discharged from the hospital unless we do this testing for them. So 17-hydroxyprogesterone will be high, but cortisol and aldosterone will be low. And usually 17 which is high, so we'll find another pathway. So try to increase the production of androstenedione, and that peripherally will be and as well. So what will happen with these babies here? So first of all, this is the most common, and it's autosomal recessive. The others all X-linked, and there is a mutation. I don't want you to know all the type of mutation. This is postgraduate, but I need you to know this one. We have low cortisol and low aldosterone, so we have hyperplasia, as I mentioned, and we have accumulation of 17-hydroxyprogesterone, and that will lead to increase the androgen excess. What happened with these babies? Usually, if it is complete classical deficiency, the female will have ambiguous genitalia, which we call the virilization, and male will have early puberty, or we call it precocious puberty. Both sexes will have rapid growth. In severe cases, salt wasting crisis, dehydration, hypovolemia, shock, and it is a neonatal emergency. But this is incomplete deficiency, like complete deficiency of the enzyme. In partial deficiency of this, it will not be happening during early. It will be a little bit late onset, and will have mild symptoms appearing late in life. So maybe the lady will have menstrual irregularities, hirsutism. So how we diagnose this, the baby, as I mentioned, is part of newborn screening program. Should measure 17-hydroxyprogesterone after 2 days of birth, classic for markedly elevated. But if we find it borderline, what we do, we call the family. Usually we have the mother file number and all the contacts. Call them to come to do give the patient or give the baby ACTH IM, give the baby a small dose of ACTH, and then we measure it again. If the progesterone increased, so this is confirmed diagnosis. And after also we ask for the patient genetic testing to study type of mutation, and this is about confirming diagnosis. And also this usually also used for prenatal screening if we also thinking, this is like we can study it. So in conclusion, 17-hydroxyprogesterone is one of 21 alpha-hydroxy deficiency. This is what I need you to know. It's in congenital adrenal hyperplasia, most common. Autosomal, we measured 17-hydroxyprogesterone, 2 forms, classical form, complete deficiency, partial, late onset. Cortisol will be low. If I ask you in the MCQs, cortisol will be low, aldosterone low, testosterone will be high, 6 hormones, virilization, and sometimes you have hypovolemia, hypotension, or in late onset. And the most important to know, 17-hydroxyprogesterone. This is the most important. Do you have any questions?